voting and officially scored on August 8 and 2021. And now we can start the Young Investigator Award. The rating scale for each topic includes research method 3 points, scientific values 3 points, practical values 2 points, report format 1 point, and report in English plus 1 point. And we will have the expected prize, 1 first prize, 2 second prize, and 3 third prize. And others will receive the motivating prize. And we can start our section now. We would like to introduce Professor Trần Giám, the chairman, Dr. PhD Đức Nhân, Associate Professor Nguyễn Anh Vũ, and Associate Professor Hoàng Tiến. And also we were happy to receive a foreign come from USA, Professor Ernest Talarico. Hi everyone, and we can start now. First, we would like to inform that we have only 7 minutes for your presentation and 3 minutes for answer the question from the chairman. Now, the first presentation, I would like to invite Dr. Nguyen Le Hoang Minh. Will present the topic endocardial 3D speckle-tracking echocardiography in patients with coronary artery disease. Please.
Hello, I'm Dr. Nguyễn Le Hoang Minh from Huỳnh University of Medicine and Pharmacy Hospital. Today, I'm going to present to you my report on endocardial 2D speckle-tracking echocardiography in patients with coronary artery disease. So let's get started. Coronary artery disease is a common disease in developed countries and tends to increase rapidly in developing countries, causes regional myocardial disorder. There are ways to detect and assess myocardial function and coronary lesions, including heart echocardiography, myocardial perfusion image, or stress test and coronary angiography. This is the nomenclature of left ventricular myocardial segments with their distribution according to coronary artery territories, including left anterior descending, right coronary arteries, and left circumflex. If there is any lesion and obstruction in each individual main coronary artery will cause ischemia and abnormal motion in corresponding wall as described in this image. What is speckle-tracking echocardiography or 2DS-TE? Speckle-tracking echocardiography has recently emerged as a quantitative ultrasound technique for accurately evaluating myocardial function by analyzing the motion of speckles identified on routine 2D sonograms. A speckle is a unique acoustic pattern resulting from the interaction of ultrasound energy with tissue. It provides non-Doppler, angle-independent, and objective quantification of myocardial deformation and left ventricular systolic and diastolic dynamics. By tracking the displacement of the speckles during the cardiac cycle, strain and strain rate can be rapidly measured offline after adequate image acquisition. The term strain can mean stretching or deformation. Velocity and displacement characterize wall motion. Strain and strain rate describe wall deformation. Because different parts of the object move with different velocities, the object will undergo deformation and will change its shape. Thus, wall motion measurement cannot differentiate between active and passive movement of myocardial segment, whereas deformation analysis allows discrimination between active and passive cardiac muscle movement. So how do we do it? 2D-STE was performed in 2-chamber, 3-chamber, and 4-chamber views by tracking the endocardial border from images with highest available frame rate. 2D-STE was also performed in the short axis to check the endocardial layer. Speckle motion was carefully inspected, and segments with poor tracking were manually readjusted and excluded if they exhibited persistently inadequate tracking throughout the cardiac cycle. This is the presentation of 2D-STE on QLab software. The software automatically traced the endocardial border from the entire left ventricle myocardium and measured layer-specific GLS or global longitudinal strain, GCS or global circumferential strain. Simultaneously, coronary angiography was performed and reviewed by 2 experienced interventionists. Both were blinded with the echocardiographic findings. Diagnosis of significant CAD were considered when more than 50% reduction of vessels diameter presents on at least one coronary artery. Here on the picture, you can see the tracing of the endocardial layer on the upper left image. Then the strain rate was calculated by the software and put on a graph. Then on the right-hand side, you can see the nomenclature of the cardiac muscle, and the strain rate will present on the picture because to help the physician to easily imagine the abnormalities of wall motion. We have 2 questions. How are the parameters of endocardial strain on 2D-STE in patients with ischemic heart disease? And the second, is there an agreement between 2D-STE and coronary angiography on the coronary lesions? To answer those questions, we have 60 participants in the average age of 60 to 79 years. Hypertension and smoking are risk factor, and also dyslipidemia. We observed the change in left ventricular function by 2D-STE. Firstly, we can see 2D-STE has a higher sensitivity and the accuracy for the detection of myocardial ischemia in each coronary artery compared to visual assessment of wall motion abnormalities. Here is the result of 2D-STE strain by the software. In healthy individuals, average peak systolic LV longitudinal strain assessed by STE is from the range of -18 to -20. In this table, strain parameters decreased in comparing to normal value. The myocardial fibers most susceptible to ischemia are the longitudinally orientated fibers that are located subendocardially. Measurements of longitudinal motion and deformation are therefore the most sensitive markers for coronary artery disease, despite the preserved left ventricle ejection fraction. We also calculate the correlation of the strain and ejection fraction, and there was a good correlation between the systolic strain and ejection fraction with good statistically significant. Then we assess the agreement between 2D-STE and DSA or angiography. These tables compare the wall motion abnormalities on 2D-STE and the coronary artery lesions. For the significant coronary stenosis, the agreement of diagnosis between 2D-STE and DSA with kappa equal to 0.34, 0.53, and 0.24 respectively in septal, lateral, and inferior walls. We found that the agreement between 2D STE and angiography is not good with endocardial setting of QLAB software to identify the segmental motion anomalies clearly viewed in 2D echocardiography may be not recognized on the endocardial 2D STE. The epicardial strain analysis may resolve this problem in these cases if we change the layer setting of the software. Conclusion, the study using endocardial strain on 2D STE shows the reduced left ventricular systolic function in patients with coronary artery disease. There is a various agreement which is not great about the location of coronary lesions between 2D STE method and coronary angiography. This is either because of the physician technique or either problems from the software itself. Thank you for your attention. If any of our respected guests have any question, I would be glad to try my best to answer. Thank you again.
A question from the teachers, from the chairman, please.
So, thank you for your presentation. And I would like to ask that, as you said, there is a lot of advantage from the two-dimension speckle-tracking. And I would like to ask, would you please compare to three-dimension speckle-tracking echocardiography? And as your opinion, so you get to do 3D or 2D speckle-tracking echocardiography.
Thank you for your question. Now I will try my best to answer. Firstly, the 3D assessment echocardiography can be very precise, and it of course will be better than 2D echocardiography, but there isn't the presence of 3D echocardiography in every department, and there is the obstacle of medical insurance and of course the price. And also 2D echocardiography can provide faster imaging, especially in patients with acute coronary syndrome. We do it fast, then we move the patient to the DSA unit. 3D can be useful in case of valvular diseases, and maybe we can try to use MRI for coronary syndrome also.
Thank you. So 3D speckle-tracking echographies need a complicated instrument, and also we have to use the EKG gate multi-bit 3D strain. So basically we use more common 2D speckle-tracking echocardiography. Thank you.
Okay. Professor Ernesto Talarico, you have some comments?
I have a question.
Well, I think it was a very good presentation. I'm more of an anatomist, so I would be curious as to why the longitudinal fibers are more susceptible. You think they show increased strain?
Okay. During our research, where we see the muscle shorten to much more during in the longitudinal strain. I mean, muscle ventricular contraction consists of longitudinal and circumferential movement. So in patients with coronary syndrome, we observe that the longitudinal strain is more affected. So according to some research, also they stated that there's various statistical significance says that the longitudinal strain is more affected.
Thank you. Professor Giang, I think you have a question now? Professor Giang. So, thank you. So we move to the next presentation. I would like to introduce Dr. Ngoc Tuan Anh for the title cardiovascular outcomes of coronary artery bifurcation disease patients underwent Minicross Technique. Please.
Good morning, everybody. I'm Dr. Ngoc Tuan Anh from the Interventional Cardiology Department of Da Nang Hospital. Today, I'm going to talk about my study with title Cardiovascular Outcome of Coronary Artery Bifurcation, the AZ patient underwent Minicross Technique. As you are unaware, coronary artery disease is one of the leading causes of death in the world and Vietnam. From 15 to 20% of PCI cases are performed as coronary artery bifurcation. Technically, bifurcation is challenging, which allows success rate and poor miss and long-term outcome. So we are carrying out this study for the purpose of evaluating cardiovascular outcome of coronary artery bifurcation disease patients who underwent Minicross Technique. Firstly, this was a descriptive study that included 33 patients with diagnosis of coronary bifurcation disease who underwent PCI using Minicross Technique at Interventional Cardiology Department of Da Nang Hospital during the period from March to September 2020, satisfying the inclusion criteria. Here you can see our inclusion and exclusion criteria of patients. These patients were evaluated for the angina and heart failure status according to the CCS angina grade and NYHA heart failure classification. After the coronary angiography lesson that certifies the inclusion criteria would be performed the Minicross Technique. The first picture shows you how to perform 9 steps of my Minicross Technique, and the second one shows the final result of successful technique. After the intervention, we retook the angiography to evaluate the flow, narrow degree, and possible post-stenting complication. The technical success were defined as performing on step of Minicross Technique without complication. In this study, the endpoint was the occurrence of major adverse cardiac event on May and how it improves the symptom of angina and heart failure after 2 months follow-up. Now we come to the next point. In our study, the mean age was 64.6 plus or minus 40.50. Regarding the A group distribution, the A group over 60 accounted for the largest proportion, 65.6%. Men accounted for the majority with the rate of 71.9%. And for our galaxy and colors conducted a study on 199 patients who performed the Minicross Technique in 2009. The mean age of patients was 62.11 by 17 plus or minus 9.75 years old. Men also accounted for the majority with the rate of 83.9%. So the age and gender characteristics in our study were quite similar to other study on patients with coronary artery bifurcation disease. Let's turn to the next issue. Coronary artery bifurcation lesions are common in individuals with multiple cardiovascular risk factors. In our study, hypertension, smoking, and dyslipidemia were the 3 most common factors. And as you can see in our study, there were no patients in group of chronic coronary syndrome. The group of patients with non-EST elevation MI occupied a large proportion in the study, accounting for 59.5%. There was 13% with ST elevation myocardial infarction, accounting for 40.6%. However, there were no statistically significant difference between them, with P more than 0.05. Now I'm going to take a look at lesion characteristics. Technically, with the Minicross Technique or the cross technique, the the angle between the distal membrane and the side brain, the higher the probability of rewiring to the side brain. Therefore, Minicross technique is often chosen a Y-shaped corner. In our study, most of the case has Y angle minus or equal 70 degrees, accounting for 87.5%. Besides, most case has median 111 less than, accounting for 75%. In our study, the majority of intervention site was the location of LED with the first diagonal brain with the rate of 46.9%. Now, I would like to move to the technical success of our study. In terms of technical success criteria, our study has 29%, which completes on step of the Minicross technique without complication and improved flow and stasis of vascular lumen. So the technical success rate was 90.6%. There were 3 patients who could be rewired to the side brain to the side brain stent struck, but failed to pass the balloon to perform the final simultaneous kissing balloon dilatation. Risk ratio was similar to the study of Alfredo Galassi et al. In our study, no complications were recorded during the intervention. This graph shows you how the mean stenosis of the vessel lumen improved with statistical significance in both location in main and side brain with P minus P less than 0.05. This is me to the minus point. Is the initial effectiveness of the Minicross technique in coronary artery bifurcation intervention. In our study, patient were examined after 2 months, evaluating the improvement in angina symptom, heart failure symptom, and MAY. So there were no case of MAY occurring during the 2 months after coronary intervention. There was still very few statistical resources in the clinical outcome of the Minicross technique in the world. So in conclusion, to the 2 study of 32K of PCI with the coronary bifurcation lesson using Minicross technique, we found that technical success rate of 96% without complication. No MAY were recorded during 2 months of follow-up, and symptoms of angina and heart failure improved after 2 months follow-up. Thank you for the attention.
Thank you for your presentation. Congratulations on your result, especially you practice with a very hard techniques. And so now you see the question and some comment from the chairman and teacher.
Yeah, I have a question.
Yeah, Professor Dàng, please.
Thank you so much for your presentation. With the young doctor, you can perform the technique like that. It's very interesting. I appreciate your results. Anyway, I have a small question. Among 32 cases of the stenosis of coronary artery like that, in the result, only about 50% of dyslipidemia. I think that it's very abnormal because the mainly of cause of the artery stenosis, not only in coronary artery, but generally of artery also. Why the level of the dyslipidemia only half of the number of patients? The second question is that why you choose 2 months as a limit for assessing the result? Why 2 months, not 1 month or 3 months and the other time, for example? Can you explain to me? Thank you.
Thank you for the question of Professor Giang. About the first question, only 50% of our patients which have the dyslipidemia is about the problem that we the lipids balance for all the patient, but with as we know, more than 90% of the patient with the coronary artery disease has caused by atherosclerosis. But in the case, we just observe 90%, 50%. It's in the fact that we did, but it's the problem that the exam amount of the patient is so small, so we cannot use it for statistical result. And the second one about the 2 months the examination, because we in this study we only use it for the initial effectiveness of the technique, and we examine as 2 months as we call about the condition. We can contest with the patient, and in the consult, our outpatient consult, which just can reject them after treatment. Yeah, it's my.
So anyway, thank you so much. If possible, you can continue evaluating for the long-term complication. Okay.
Yes, that's proper. We have a plan to the exam, re-exam as 6 months and as 1 year too. And after that, we will do another result for evaluate the effectiveness of the Minicross Technique after that. Thank you for
my two ID, but it's one ID only, because you see for a long time for the long-term complication related with the risk factor. Among the risk factors of the coronary stenosis like that is dyslipidemia. So we don't let the patient without the following for a long time, so they can let's some the false result. Okay.
Okay. Thank you.
Thank you.
Yeah.
So just one question: can you distinguish the Minicross and DK cross?
Yeah, okay, thank you for the question. And in the about the technique, the 2 standard category for the coronary bifurcation disease, there are many, but such as the QRS, the DK cross, and the Minicross, and many one more. But the DK cross and the Minicross, we have a difference between the firstly the DK cross. We will do the double kissing balloon, double kissing balloon after the employment of the membrane stent. And when we rewire to the side brain in the Minicross technique, we use the proximal stent stroke to the side brain, and the DK cross we use the distal stent stroke. And in the Minicross, we left about 8 to 10 millimeter of the main stent of the main brain stent to do the POT after the employment of the second stent. And about the Minicross, we will do the balloons, the NC balloon dilatation after the employment of the stent in the membrane, with not parallel to the balloon in the side brain to do the simultaneous kissing balloon dilatation.
So DK cross is better than Minicross, or Minicross better?
Okay, in the problem that in that period of the study, we are used to do the Minicross technique, but now to evaluate the coronary bifurcation stenting, we realize that the DK cross is more comfortable and more safe for the patient. So now, right now, at this moment, we do DK cross technique more than the Minicross technique.
Yes, nowadays we use the Minicross more than the DK cross more than Minicross.
Yeah,
because safety and effectiveness. Thank you.
Thank you for your participation. And the next presentation, I would like to present Phạm Quốc Dũng, student from Duy Tan University. Please.
Everyone, first of all, let me say pleasure to welcome all of you today. My name is Phạm Quốc Dũng, one student conducting this research along with me and my team. without support and supervised by PhD Doctor of Medicine, second degree specialist in internal medicine, Hoàng. Today, I would like to talk about what we find out about the position of K21 YDK students about home blood pressures monitoring methods. My talk will be divided into 4 parts. As you may know, hypertension or high blood pressure are often referred as the silent killer. Hypertension is one of the leading causes of death and disability. In fact, about 39.1% hypertension cases are living without knowing about it. 69% hypertension patients are under treatment but have to achieve the target blood pressure. In some cases, blood pressure measured at clinic are normal but unexpectedly mount to the peak at some point. So with the measurement at home, we're able to identify accurate changes to blood pressure at any time in the day, at any habitus. Hence, the instructions for measuring blood pressure at home is essential. With that being said, we want to conduct this study or two major objectives about studying about recognition of students and also the relevant factors. About methodology, we take the variables like general information and perception of volunteer based on GS.TS, which is the Japanese Society of Hypertension, and gender age. In our questionnaire, we focus on values of raising method, device recommendations, accurate measuring methods, GS.TS guidelines. The questionnaire had 21 questions. We conducted with the agreement of the board of manager of Duy Tan University, widely without question. And what we find out is 55% of volunteers are male, 45 are female. The majority is 23 years old, takes about 70%, and more than 24 is 30%. And the 4 questions is, would you like to recommend hypertension patients to self-check the blood pressure at home? According to guideline of GS 2009, self-check blood pressure at home are significant. Furthermore, the Vietnam Heart Association measuring blood pressure outside the clinic or office is recommended, incorporated with remote consulting and clinical interference. According to our study, 83% of students choose yes. One important factor is the best options to measure blood pressure in order to get the most accurate results. According to the guidelines of GS.TS, the best options are around 1 hour after waking up and going to bed and before going to bed at sitting positions. 60% volunteers in our research choose the both option or both. And so, clinic, office blood pressure, CPP, or home blood pressure, HPP is more valuable for diagnosing and treating hypertension. According to our research of student and college on 400 patients or home blood trial, there's no significant differences between CPP or HPP. And also, home blood suggests that people who are under pressure monitoring at home tend to take less medication and medical costs. Only 45% volunteers choose the both values. So how many times should we measure blood pressure at each occasion? More than 60% of volunteers choose measure blood pressure twice a day. In addition, both GS.TS and research of mandate advice to note down every value, no selective, which are recorded during both occasions in order to appraise the blood pressure at different times of day. In our study, only 34% saw the answer then. So which devices should be recommended to patients? 83% students pick the upper end cuff device. This is true for GS 2009. And about the value for diagnosing and treating hypertension. GS guidelines on both European Society of Hypertension and Cardiology in 2018 advised to surely diagnose hypertension when HBP is more than 135 on 85 millimeter mercury or CPP from 140 on 19 millimeter mercury. 98.8% have the correct knowledge about CPP. However, only 23.9% know the right numbers for diagnosing hypertension by HPP. This indicates the lack of accurate knowledge about awareness for diagnosing hypertension by HPP among people in Vietnam, even medical students. To sum up points by questionnaire in our study, the mean of questionnaire points is 13.2 with the derivation of 3.7, or 15 with the standard deviation of 4. About relevance, we took the combination between age, gender, and recognition of GSH in CPP and HPP with the B value greater than 0.05. We did not find any relevant factors that affected recommending self-check blood pressure at home. And this is our limitation, so that we indicate the need for doing further research so as to find more independent and valid factors in much larger population. And in our conclusions, 83% of students told the concern about measuring blood pressure at home. I also know the best recommended device for measuring blood pressure. Almost 100% know the correct values for CPP for diagnosing hypertension, while only 24% being able to answer correctly values of HPP. The mean of questionnaire point is 13.2. About relevant factors, the proportion of student awareness twice graduate according to their age. Female students told the better perception. However, it is not significant for statistics. And lastly, is our recommendations. To raise the awareness for students and preparing the significance and purpose of home blood pressure monitoring, popularize blood pressure monitoring to students, and also join activities for national hypertension prophylaxis program. Encourage cooperation between medical students and medical in order to help people. A hypertension patient have the accurate awareness about home blood pressure measurement. And these are some of our reference. Thank you for your listening.
Thank you for your presentation. And now the next is the question from the teacher, from the chairman, please. But because limitation of time, we have only one teacher can give his questions only. So I would like to have some comment concerning about your presentation. First of all, congratulations for your success on studying in a team of students. But can you explain the differences between the awareness and different of the answer between the older and the younger student? Why? Can you justify the difference between the awareness, the student 23 years old and 25 years old? What is the difference?
Well, thank you. First of all, thank you for your questions. Actually, we took this research on 83 students whose age which range on 23 to 25 years old, and because of that, I think for some students are teammates and classmates, and they are studying together, but some of them are older than the other, because I think because they will study about it before the others, so that's why they have some of the knowledge that's better than the other. So I think that is the mostly reason why they know more. Their perception of the blood pressure is more better than the age from 23.
Okay, maybe when they become older, they will terminate their study, or they are concerned a lot about their practice, you know. So they read a lot of the document concerning about the hypertension, very important problem now. Thank you. So thank you very much. The next.
And now the next presentation, I would like to introduce the student Nguyen Vu Ha Nguyen. Is the topic hypertension screening result amongst others university, the 3M 2019 campaign, please.
Ladies and gentlemen, my name is Nguyen. I'm a medical student of Huỳnh University of Medicine and Pharmacy. Before starting my presentation, I would like to offer my thanks to my supervisor, Professor Huỳnh Minh, for his continuous support and instruction, and also give my thanks to this organizer of this conference. And so today, I represent for my cardiovascular club to present to all of you about hypertension screening result among adults of Huế City, according to the main measurement campaign in 2019. This is the structure of my presentation. To begin, let me give you some information about the big deal of rise blood pressure and the main measurement campaign. Rise blood pressure is continued to be the biggest contributor to mortality and disease burden worldwide, leading to 10 million deaths this year. As you may know, hypertension is a silent killer. This is because it has no symptom. And maybe until you are hospitalized for emergency hypertension or for its complication like stroke or myocardial infarction, that you really know you have it. Despite its serious concern, just half of the hypertensive population are aware of their condition. Normally, the hypertension is testable, and the simplest way to detect this disease is blood pressure measurement. And these are also the main objective of the main measurement campaign. This picture illustrates some hypertension risk factors. Here is the two main objectives of our study. Firstly, we would like to estimate the prevalence, awareness, treatment, and control of hypertension among adults in Huế City. Secondly, we also evaluate the relationship between hypertension and some of participant characteristics. Let's move to the materials and method. Firstly, I would like to talk about study design and population. Our study is a cross-sectional study with convenient sampling. The total number of participants in our study reached more than 6,000 people. A wide range of locations were set, including hospital, health center, and public areas like supermarket, shopping mall, or school. This survey was conducted in 1 month from May to June in 2019. These are some criteria of participant selection. The target participant of our study is adults who have well physical and well mental health. Besides, we also have some requirement for the participant before measurement to ensure the accurate result, like not using symptomatic drug, not using caffeine beverage at least 1 hour, no smoking at least 15 minutes. Regarding to the inclusion criteria, we include people who refuse to attend the study or timing inadequate for duplicated measurement, and the patient being hospitalized for their hypertensive condition. There are 3 standard steps in blood pressure measurement. Talking about data collection. Firstly, the participant will ask some questions about their demographic and hypertension risk factor through this questionnaire. In the second step, their systemic blood pressure level have been measured 3 times by an automatic sphygmomanometer. And the result were calculated from the mean of the second and third reading. Here is the standard guideline of blood pressure measurement. And here is the real condition when we conduct the measurement for the participant. We use SPSS and R software for statistical analysis. In the next slide, I will move to the result and discussion. Following imputation, 6,156 participants were included to analysis. They had a mean age of around 43 years, and the mean systolic blood pressure and diastolic blood pressure were 115.62 and 75.41 millimeter of mercury, respectively. Furthermore, the blood pressure level of men was significantly higher than those of women. This picture illustrates most of the men objectives of our study following imputation. Nearly 1,500 participants were found to have hypertension, accounting for approximately 24% among the total. And among hypertensive group, just about 1,000 people who had a previous diagnosis of hypertension, corresponding to 66.1%. And the proportion of gestational hypertension is nearly 70% among the participants who were aware of their condition, and less than 60% of them were successfully controlled. Thanks to the success of the main measurement campaign, there was a rise in the hypertensive awareness. It has been increased from nearly 61% in 2015 to over 66% in 2019. And besides, there was a relationship between gender, tobacco consumption, obesity or overweight, and diabetes with hypertension. And especially in the analysis, we found a strongly associated between hypertension and history of myocardial infarction and history of stroke. Let's move to the conclusion. To summarize, the finding of the study indicated that hypertensive prevalence of adults in obesity remain high and tend to increasingly rise in comparison with other studies from 2018 to present. In comparison with other studies, awareness of hypertension has a tendency to progressively increase. The number of gestational hypertension were not really high among the prevalence of hypertension. And among the group of participants who received antihypertensive treatment, the controlled hypertension were quite low. There are some participant characteristics with strongly influences on the impact of hypertension, including smoking, men, overweight or obesity, diabetes, history of myocardial infarction, history of stroke. Furthermore, I would like to talk about some recommendations for the clinician. Firstly, the blood pressure level should be measured on at least 3 occasions according to the standard protocol of the International Society of Hypertension, and the average of the last 2 measurements were calculated and used for the diagnosis and treatment decision. The clinician should consider both non-medication and medication approach for treatment of hypertension. Last but not least, there are most benefit from maintaining and expanding some meaningful campaigns like the main measurement program to other parts of Vietnam for early detection, raising awareness, and providing better treatment of the hypertension. Finally, I am honestly happy to be presented in this conference. Thank you so much for your attention. Sincerely.
Thank you. Thank you for the presentation. Is there any question about this topic? Professor Ernest Talarico, please.
I have a question.
Professor Zhang, please.
Thank you so much, Ha Nguyen. You are a student, but you performed scientific research like that. It's very good. Generally, I appreciate the result. Anyway, at this occasion, I have some comment that your study the focus in the prevalence of hypertension in Hue city. While you use the Hue city, the sample collected, but based on in real activity, not only based on the hospital and the health center, but it's not typical of the hypertension prevalence of the Hue city. So if possible, you can send your topic, your article, about the hypertension screening result among adults in the Hue Central Hue Hospital or Hue Public Center Center Health instead of in Hue City. That's the first important. There are two factors for result of public health related concern the prevalence, that is the sample, the number of object with 60,000 like that is enough, but the result is not typical of the Hue city. The second question is that it is a cross-sectional study, so you cannot conclude that that is the result of the hypertension increase with the time. Of course, you can base on the result of the other doctor, the other subject, the other author in the other area, the other time to compare with the result today. But while you conclude that the prevalence of hypertension increase, that is your cell, the result of your cell with the time, many times. You see, that is the comment only. Anyway, finally, I can say that I appreciate your study. Anyway, comment only.
Yeah, thank you so much for your comment.
Professor Ernesto, Talarico, do I have any question?
It was a very nice presentation, great job and nice research. I'm curious though, as to why you feel that hypertension is increasing. Why is hypertension increasing in your population? And if awareness is increasing, why isn't hypertension decreasing? What is the disconnect and what needs to be done to overcome that disconnect?
Thank you so much for your question, but I'm sorry I have some problem with my connection. Can you repeat your question, please?
Sure. I'm curious as to why you feel that hypertension is increasing. And in your study,
ông hỏi là sao mà cái tình
your study indicates that awareness of hypertension is increasing. And if that is the case, why is there a disconnect? Because if awareness is increasing, then you would think people would be more aware, they would watch diet, they would watch obesity, and the incidence of hypertension would decrease.
You're talking about the rise in awareness of public about hypertension. I think thanks to the success of the May Measurement Month campaign, we conduct this campaign continuously from 2017 to now to 2019. Yeah, with the success of this campaign, we can raise the awareness of public about hypertension.
And do you think that in part that the increase in the incidence of hypertension could be secondary to the introduction of westernized foods?
Yeah, I think it is, of course, thanks to the success of this conference, we can have the chance to give more information about dietary lifestyle change to the participant. Yeah, it can, in order to have to increase the awareness of public, is also contribute to the successful of the campaign.
Thank you.
Thank you. And now the next topic is in Vietnamese. Dr. Đoàn Phạm Phước Long nghiên cứu hiệu quả của thuốc SGLT2 inhibitor ở bệnh nhân suy tim mất mù cấp có đái tháo đường type 2.
Dear Professor, in the Central Vietnam Virtual Congress of Cardiology, my name is Long Duong from the Huế UMP. Thanks for having me, and today I will present a research of the efficacy of SGLT2 inhibitors in acute decompensated heart failure with type 2 diabetes mellitus. So the sodium glucose cotransporter 2 inhibitors is a class of medication treating diabetes, and it is now to become the first-line therapy in diabetes patients with heart failure or at high cardiovascular risk. And unlike chronic heart failure, there is no established therapy available that improves the clinical outcome in acute heart failure. And we have hypothesized that the SGLT2 inhibitors exert positive effect in the patient admitted with the acute heart failure and diabetes. So to answer that question, we designed a prospective case control study with 1 month follow-up on the patient admitted to the cardiology center of Huế Central Hospital who were diagnosed with diabetes, admitted to the hospital with hypervolemic acute decompensated heart failure with reduced left ventricle ejection fraction. Patients were assigned into 2 groups based on the patient choice. One is protocol diuretic titration and usual care with 51 patients, and group 2 is the same with addition of dapagliflozin 10 mg per day with 37 patients. There are several exclusion criteria, especially patients with low systolic blood pressure and very low GFR, and patients require inotrope therapy. The primary endpoint of this study is the length of the hospitalization, in-hospital death within 30 days after discharge, and readmission within 30 days after discharge. The safety endpoint is urinary tract infection, worsening renal function, ketone acidosis, hypotension or hypovolemic shocks, and discontinuation due to adverse effect. And the study has the significant level up below 0.05. And after 6 months of, with 88 patients, we have some results. About the baseline characteristics, there are no significant difference in age and gender between 2 patient groups. And it is the same to the vital sign. About the medical history, the notice is that there were only about 50% of patients had been diagnosed with the heart failure before admission in both 2 groups. The baseline lab examination were taken at hospital admission, and there were no significant difference between 2 patient groups about the lab test. But compared to the EMPA response HHF trial, the left ventricle ejection fraction in our study were more severe, with average of 30%, while the EMPA response HHF trial were about 36%. About the efficacy of the SGLT2 inhibitors, as the result, the proportion of in-hospital mortality and 30-day mortality after discharge tend to be higher in the group of patients not using the agent. The length of hospitalization by day in patients not using the SGLT2 inhibitors is higher, but not significant. But the point is, the number of the patient readmission within 30 days of discharge is significantly higher in patients who do not use the SGLT2 inhibitors. So we did a Kaplan-Meier analysis to compare the re-hospitalized, and the result was the patient group of non-SGLT2 using re-hospitalized sooner than the patient using the SGLT2, and the 2 groups has a remarkable difference after 10 days after discharge. In the secondary endpoint, we study about the improvement of the ejection fraction, the GFR, the BNP, and the fasting plasma blood glucose. And both the patient groups has the improvement in ejection fraction, but the group of SGLT2 inhibitors seem a better improvement. About the GFR, the patient used the SGLT2 inhibitors show significantly improvement after 30 days of discharge, but in day 4, it shows no improvement. In patients who don't use the agent, the GFR gets significantly worse in the day 4. Then it improves again in day 30, but not significant. Both the two patient groups reduce significantly the anti-proBNP and fasting plasma blood glucose, but the group of using SGLT2 inhibitors seems much more effective. About the safety, the number of total adverse effects of 2 patient groups was small. The 2 complications that should be considered in the patient using SGLT2 inhibitors were urinary tract infection and discontinuation of treatment due to the feeling lose weight too fast. So you colleagues should pay attention into patient explanation in clinical practicing. This study has several limitations. First and foremost, this study is limited by the number of patients and should be considered as a pilot study. Secondly, the number of missing urinary collection and fluid intake limit the interpretability of the data. And finally, there was no standardized protocol for in-hospital treatment of acute decompensated heart failure, and this may impact the result. So throughout the study of 88 patients, we have following conclusion. First, about the efficacy of the SGLT2 inhibitors. The using of SGLT2 inhibitor may reduce the rehospitalization rate in first 30 days after discharge, and the using of the agent may prolong the duration between the hospitalization period. And only the patient group using the SGLT2 inhibitors could improve the GFR after 30 days. About the safety of using SGLT2, there were no ketone acidosis, hypovolemic shock seen in the patient use SGLT2 inhibitors, and urinary tract infections and loose weight were 2 problems seen in patients using SGLT2 inhibitors. So thanks for attention.
Thank you. And I would like to Professor Zhang.
Yes. Thank you so much. I think that that is the drug at first for diabetes mellitus is set up for heart failure. But today, your study focus in the result of the heart failure of the SGLT2 inhibitor. So it's very interesting. Anyway, at my knowledge, the recently the FDA and ESC approved this indication of the SGLT2 inhibitor for heart failure. But in Vietnam, until now, we don't have the approval of the Ministry of Health. Attention. Anyway, we in terms of the activities of the Association of Vietnam Diabetes and Endocrinology, that we suggested with the Ministry of Health, and I hope that in next month, I think in September, I think we will have the approval by the Ministry of Health for this indication. So I highly appreciate it. Although with the limited number of subjects, anyway, the theory of the indication of the management of the heart failure of the SGLT2 inhibitor on the world is very clear. So that is a very advanced result of one young doctor of the University of Hospital. Thank you so much. And anyway, with the short the subject, anyway, I focus that you don't see any cases of ketoacidosis, but that is one complication severe in indication of and side effect of the dapagliflozin. So besides that, you focus only the infection of urinary, but the genital infection. Genital infection, that is another complication. So I comment only. I appreciate the result. Thank you so much.
Yeah, thanks for your comment, Professor Yang.
So the next, I would like to introduce student Lâm Như with the topic, the cause effect correlations between cavitation phenomenon and lesions in coronary artery. So I'm sorry.
Good morning, ladies and gentlemen. I miss Lâm Như.
Con Khoa này.
Khoa chứ.
So I'm sorry. So the next year, I would like to invite Dr. Phang Anh Khoa with the topic case report vision loss after myocardial infarction, revascularization. So please give presentation.
Dạ, kính thưa quý chủ tọa đoàn và quý đồng nghiệp, ngày hôm nay tôi rất là vinh dự có mặt tại hội nghị tim mạch miền Trung Tây Nguyên mở rộng lần thứ 11 và có bài trình bày của mình dưới dạng là báo cáo ca lâm sàng. Chủ đề ngày hôm nay đó là mất tầm nhìn sau can thiệp nhồi máu cơ tim, và tôi xin phép được trình bày bài báo cáo bằng tiếng Anh. Ladies and gentlemen, it's an honor for me to be here and present a presentation as a case report. I am Dr. Khoa from Huế Central Hospital. Today, the topic is visual loss after myocardial infarction revascularization. As you may know, loss of vision or visual loss is considered a sudden if it develops within a few minutes or a couple of days. It may affect one or both eyes and on a part of field of visions. Today, I will go to step by step from case report, an overview, and do we have any suitable strategy? And finally, we will take a home message. The case report. The 64-year-old woman patient presents with acute angina and shortness of breath. The medical history is the diabetes mellitus type 2 with a glucose 1,000 per day milligram and hypertension stage 1. The blood pressure at the hospitalization is 90 per 60. The heart rate is 90 BPM and oxygen saturation is 90%. The ECG show at the ER room is XD segment elevation at V1 to V4, and left ventricle ejection fraction is about 50%. And she was diagnosed with acute myocardial infarction, STEMI, and had an emergency PCI performed 1 hour euthanasia. And this slide showed a video with total occlusion at the proximal of the LAD. And when we put the wire and the balloon into the proximal of the LAD, we can see we don't see any flow at the LAD. And after stenting, the flow of the LAD become more back to normal, TME3. Especially revascularization with a DES stent was performed, but after deploying, the systolic pressure was quickly damping from 90 to 50 and to 30, and ECG show ventricle fibrillation. You may know the condition of the patient become more analogous. And we decide to chest compress and get first defibrillation with intravenous administration of sodium bicarbonate and adrenaline. After a few minutes, approximately about 3 minutes, the ECG become back to silent tachycardia, and the condition of the patient returned to have a good peripheral pulse, spontaneous respiration, and recovery of responsiveness. And totally, the time of shock condition was less than 3 minutes. You can see the final result of the PCI, this picture, the good result of the LAD with the DES stent and the TME3 flow at the LAD. And after the shock of patient, the patient suddenly got visual loss in both two eyes immediately after the procedure. And she couldn't see anything. All her view was black. Her pupils still react to light. The funding were normal. Superficial neurological examination revealed no abnormality. She was transferred to ICU room of my department, emergency cardiovascular department, with a closely monitor. At the first time, I and the relative person of the patient is a little confused because we don't fight, we scare about the many complications. Do I let the rupture of the vessel to the retinal and make a retinal emboly? But after 3 hours of following up, her condition was better with my chest pain and vision got back to normal. We had a discussion with ophthalmologists, and detailed ophthalmological examination revealed that visual acuity and visual field test on a perimeter and a fundie was on normal. And a discussion between the neurology and interventionist is complete neurological examination and carotid examination was performed and received normal result. CT brain showed no significant abnormality. And we decided to have a diagnosis in this patient is transition cortical blindness. We can see that the etiology of the visual loss is symptom, but the etiology is many reasons cause visual loss. And in the scenario of revascularization of MI patient is a rare complication, and that may caused by some reason, including transition cortical blindness as an expression of cerebral anoxia, and retinal artery occlusion due to thromboembolic events that may happen in the intervention process. And blindness in this case, we probably think about the cerebral anoxia, and they are unusual because blindness was not accompanied by other neurological signs, because everything we examined is no abnormality. And the you may know at the anatomy site, the brain received its blood supply from the both middle and posterior cerebral arteries. Although this dual blood supply tends to lessen the extent of ischemic damage when only one vessel is occluded, it does not protect this area from damage when there's general hypoxia, for example, cardiac arrest and prolonged hypertension, especially in this patient. And another reason is retinal damage. The incidence of new retinal emboli after revascularization is about 6.3%, according to the code jury at the BMC cardiovascular disorder at 2011. And the risk factor is age, hypertension, or operator expertise. The mode of the procedure and severity of the coronary artery disease had no effect on the risk of retinal emboli. And finally, according to many information about the transition cortical blindness and retinal emboli and some other visual loss complication, we conclude some messages. First, visual loss due to transition cortical blindness is a rare complication post-cardiovascularization with a hemodynamic instability, but have a good prognosis if patient got a good recovery in short period of time. 2. Retinal emboli must be ruled out with a careful discussion between physician and ophthalmologist and neurologist as well. The shorter time of getting back to recovery after revascularization of myocardial infarction patient. For example, we have a good CPR, we have a good ACLS, intravenous, put the vein, shock, defibrillation, everything. We take the condition of the patient back very quick, the better outcome of application. And the patient will get back to normal very soon. Thank you for listening.
Very thank you about your presentation. It's very interesting case and rare case, and you present is very clearly. So we have two questions from Professor Takmir, and you answer very shortly. The first is how much contrast did she receive? The second question is how long were the time of angiography and stenting? So please answer very briefly.
Thank you about the question of Dr. Thạc Nguyễn and the jury. In my case, the time of the revascularization is just about 30 minutes, and the amount of the contrast agent is about 100 milliliters. I know that the transient cortical blindness is a rare complication that may related to an angiographic contrast agent, and I don't have any proof to prove that the angiographic contrast agent rule out in this case. So the angiographic contrast agent may be one of the reasons why patients have the transition cortical blindness in this patient. Thank you very much.
Next topic. So I would like to introduce student Lâm Mận Như with the topic, the cause effect correlations between cavitation phenomenon and lesions in coronary arteries. So please give your presentation.
Good morning, ladies and gentlemen. I am Ms. Lâm Mận Như, and it is my honor to present you the research, the cause-effect correlations between invitation phenomenon and lesions in coronary artery. Before starting, please keep in mind that the presenter and the co-author have no relevant financial or commercial relationship to this course. And here's the overview of my presentation, showing as a graph chart. Our hypothesis is based on the observation of damage caused by air bubble structure in domestic and industrial parts. This is also called the cavitation phenomenon. Basically, the mechanism is when the static pressure is less than the vapor pressure, then the bubbles are formed. In contrast, when the static pressure is higher than the vapor pressure, then the bubbles will implode. The research team select the coronary angiogram with 1 to 2 lesions. Frame by frame, at 15 frames per second, the angiogram will examine for plaque location, time and length of coronary segment turbulence, reversal flow, and stagnant flow. The coronary artery should be properly contracted and should capture the whole artery in full length with all the frames totally inside the screen. Then stop the injection. At the moment, blood in white color flows in, and we saw the movement and interactions of the coronary flow. To review, right-click and choose the key image. To go through each frame, use the up and down buttons. Moving on, we need to review some kind of classifications in CAD. The first one is the classifications of coronary lesions, including three types. Type 1, shock-concealed lesions of moderate severity. Type 2, shock-mill lesions. Type 3, minimal diffuse lesions. Not to mention, the classifications of flow abnormality also have three types. Type A, laminar flow. This is well-organized flow in parallel layers with a pointed tip. Type B, turbulent flow, is represented as a disorderly mixture of black contract and white blood. Type C, retention peripheral flow, non-zero segment contract at the peripheral layers. When it comes to the flow chart in matching lesions with flow, here's what the research team is going to do. In each patient, doctors will separate the coronary artery into three segments: the proximal segment, mid-segment and at the stop line, and the distal segment. In each segment, doctors will go through step 1. Find out which types of that flow. It could be A, B, or C. Step 2. Determine all kinds of lesions from 1 to 3. Step 3. Find the stop line. And step 4. Match lesions with flow. Working on the research of 50 patients, here's the demographic and clinical features. Almost all the patients are elders. The percentage of female is slightly more than male. About 30% of them smoke. Here, the research team also notes the patient's comorbidity, including dyslipidemia, hypertension, diabetes, previous heart failure, and anemia. In cardiovascular physiology, the flows were antegrade, rapid, and last 0.24 seconds to 0.3 seconds at the beginning of diastole. The antegrade flow then stopped for 0.6 seconds due to retrograde flow at the beginning of systole. This was identified at the stop line. So again, the stop line marked the location of the most turbulent flow resulting from a condition between the antegrade flow of systole and the retrograde flow of diastole. For instance, you can see on screen frame 36 of RCA. At the beginning of systole, the flow was stopped mainly in the central of the mid segment, where the contract was found to be trapped, the arrow. You can see it more clearly the contract in frame 37. In order to analyze the result, here's the graph showing the percentage of lesions based on location at the stop line and not at the stop line. As can be seen, among 102 coronary lesions of 15 patients, 76% were found at the stop line, while only 24% at the non-stop line location. Comparing the lesions at the stop line of each patient with the lesions in the two other coronary arteries, the lesions at the stop line appear earlier and grew faster, or become more severe, in 76% of cases, which means about 38 over 50 patients. If there was a turbulent flow lasting more than 0.3 seconds, which is 5 images, then at the stop line, the change for a severe lesions was high, at 34%. If there was a shorter turbulent flow, the lesions were less severe, about 65%. If any of these lesions were found next to a side brain of mild to moderate size, they would be the most severe stenotic lesions between all the coronary lesions of the same patient, 12 over 26 cases, or about 46%. Finally, may I remind you some of the main points we've considered. 1. The most common locations of the coronary lesion was at the stop line, where the antegrade flow collided with the retrograde flow. 2. Here at the stop line, the lesions grew faster, so the lesions became more severe compared with other lesions of the same patient. 3. The new technique of angiography reviewed the dynamic flows and their correlation, open new chapters in the clinical and interventional management of CAD. That brings me to an end of my presentation. Many thanks for your attention. I'll be glad to answer questions you may have.
Thank you for your presentation. I have a question for you. Do you know because I see that you show the relation between the pressure and no. The velocity and the pressure. Do you know, is there any relation between the velocity and the pressure in the vessel? There is a question. Do you know the name of the this question? A question is the relation between the pressure and the velocity. You know.
Yes, yes, first, thanks. Can I answer now? So the velocity and the pressures based on the Mendeleev's principle. Let me explain further. That means when the blood goes through the narrow part of the coronary artery, the velocity is high, and also the pressure is low. There's a connections between them because it's based on the Bernoulli's principle. For example, when going through the narrow part of the coronary artery, the pressure is low, while the velocity is high. So then we will have empty space after going through the narrow part of the coronary artery. So then, as what I mentioned in the presentations, it will cause empty space. Then it will cause bubbles rupture easily. Then it would be the most dangerous diagnostic lesions.
Right. I think the velocity and there is a correlation between the velocity of the flow and the pressure in the vessel. And this there is a equation named Bernoulli. So the relation. The pressure is 4 times of the velocity square of the velocity. That means the velocity high gives the pressure high also. And that's why the velocity and the pressure play and role is a lesson of the vessel. I think. That, is there any question about?
So thank you for your answer. We would like to move to the next topic. So I would like to introduce the student Ngoc Tuan Anh with the topic prolongations of the arterial phase in the underlying pathological process in women with syndrome X. So please give your presentation.
Good afternoon, ladies and gentlemen. My name is Cao Thanh Bình. I'm a student of Untitled University. Today, I would like to present about prolongation of the arterial phase is the pathological process underlying a syndrome. Before starting, please keep in mind the presenting author and co-investigator have no financial interest, arrangement, or commercial affiliation to disclose. First, I would like to talk about the background. Frequently, women present with symptoms atypical angina pectoris, making ischemic heart disease recognition. As you all know, angina pectoris can be identified as typical angina pectoris as TAP, atypical angina pectoris as AAP, or pseudo angina pectoris as PAP, and a form of AAP called cardiac syndrome is defined as a chest pain with evidence of myocardial ischemia. In the absence of coronary artery disease, the pathological mechanism remains unexplained. That's why the aim of these studies was to examine coronary blood flows based on the novel angiographic technique to explain the mechanism of chest pain and associated symptoms in patients with cardiac syndrome X. Take a look at this. You will see these angiograms were done with the new technique. As the contrast injection stopped, the blood in the white color move in and display the black contrast. And during injection, the camera could record the index artery in its full length at 15 images per second. And characteristics of blood flow could be observed and classified by times and time. Therefore, the duration of the artery phase were calculated and compared with control. Now, come to the method. All the patients who enrolled in this study were divided into two groups. The study groups includes 10 patients with confirmed cardiac syndrome X after angiography, and the control group includes 10 patients with normal coronary artery with the left ventricle ejection fraction more than 50% and confirmed non-cardiac causes of chest pain. The patients were excluded if they have significant valvular disease, unstable angina, mid to the severe coronary artery disease. And through the new angio technique, calculate and compare the time of the blood passed through the each segment of right coronary artery, left anterior descending artery, left circumflex artery. Here is the angiogram of the right coronary artery. The blood moves from the entry to the beginning of the mid-segment, to mid-segment, to the beginning of distal segment, and to posterior distal artery, and to the end. The blood flow measurement were divided into 4 time periods for comparison. And the first period here, the second period, the third period, and the fourth period, when all the contrast disappear from the arteries. Now, move to the result. Here is the demographic and clinical feature of the research are summarized in this table. All of them are elderly. The female more than male. The cigarette smoking is about 30% and have some comorbidities such as diabetes, hypertension, coronary artery disease, previous heart failure, anemia, and dyslipidemia. As you remember, the duration of arterial phase was calculated and compared with the control. This table shows the result, and the syndrome X groups was divided into 5 small groups, depending on the contrast remaining in the arteries. Here, coloring some information to make it easier to pay attention. In the control group, the duration of the time from blood entry to the end was 1.5 4.52 seconds, while it was 3.79 seconds for the syndrome X groups. And the primary delay, which made the large difference, was the period of time when the contrast left the posterior distal artery to the end, and the second delay from the mid-segment to the beginning distal segment. The patient with the cardiac syndrome X had a much longer delay. And syndrome X patient with prolonged myocardial phase had dense and prolonged contrast retention at the myocardium. Now, let me summarize. In the syndrome X patient, the prolonged arterial phase deprived the myocardium of highly oxygenated blood and triggers ischemia. The new image method allows for the better understanding the mechanism of ischemia in syndrome X patient. However, the limitation of the study was that it was a non-randomized observational study with a small number of patients. A large cohort needs to be enrolled to be applied this finding within the general population. As for the innovative application, there are many questions. For example, what option does the cardiology have to offer to the cardiac syndrome X patient? Or what is the role of beta blocker in this type of functional ischemia? Or does biventricular pacing help? Further studies are needed to be clarified the aforementioned and intriguing question. That brings us to the end of my presentation. Thank you for your listening. Now, I'll try to answer any question if you may have. Thank you.
Thank you for your presentation. As we know, there are two types of X syndrome. This is the metabolic X syndrome and coronary X syndrome. And now the definition of coronary syndrome. Maybe we can use Minicross syndrome. Minicross syndrome that it looks like the type 2 of acute myocardial infarction. It shows the vasoconstriction and without the lesion. For example, the atheroma in the lumen of the coronary artery disease. So with a limited number of patients, 20 patients, but I see you have a big effort to perform your study. Thank you. But I would like to know do you perform the coronary angiography, or you collect only their result to describe and study? Yes. Can you answer the question?
Yeah.
Student Cao Bin.
Yeah. Good morning.
You will perform directly the coronary angiography to study, or you collect only the result of other doctor, other interventionists to describe and to study? Do you perform angiography directly? Yourself?
No. No, this is the research of my leaders. I just presented. So.
I have a question.
Yes, sir.
I have a question.
Yes, I'm listening.
So anyway, generally I high appreciation or effort, but in Vietnam, you should focus very important. That is a practicing certificate. Practicing certificate very important. with the technique, invasive technique like that, can result, can cause the death of the patient. That is a permission for a student. It's not permission for a student. So with a student, you should focus on the technique for study based on the practicing certificate by authority of medical health. I'm very strange that with a student like that, you can perform the invasive technique like that can cause the death of patient. It's not permission. Okay? I don't agree with the result. That is the result of the other doctor is not you fail. You real. I don't agree with the result. That the result of the other doctor is not instead of yourself. In our activities, we don't accept the result like that. That is the result of the other doctor. Okay?
Yes, thank you, sir.
So you tried is good, but you should limit your capacity with the permission by the authority of health. Okay?
Yes.
Thank you.
Thank you.
Cháu Chị Nhã with the topic mechanism of sudden death in patients with the patent coronary arteries and aortic stenosis. So please.
Hello everyone, my name is Châu Chí Nhã and today I will present the mechanism of chest pain and stenosis in patients with aortic stenosis and patent coronary arteries. There is no relevant financial or commercial relationship between the presenter and co-investigators. It is well established that patients suffering from aortic stenosis can present with chest pain, syncope, and sudden cardiac death despite abnormal coronary arteries. In the prior studies, the mechanism has been unknown. So, the goal of this study is to answer the question why by using the new technique, coronary angiography. Patients with complaints of chest pain, shortness of breath, and syncope were screened for aortic stenosis by using echocardiography. Then they underwent coronary angiogram. And if the diagnosis of aortic stenosis was confirmed and the coronary arteries were normal, then the patient was included in the study group. In contrast, patients under the age of 35 admitted with the same complaints and showed normal coronary arteries and normal left ventricular function without aortic stenosis served as control. All subjects underwent bilateral coronary angiogram with right heart catheterization, and the coronary flows were recorded 15 frames per second. From data from electronic health record, we retrieve the entire angiogram and examine the series. While the angiogram is running, we make the right click on the mouse and choose this key image option and review the images with up and down arrow keys, one image at a time. During angiography, the camera was positioned at specific angles so that the next artery could be captured in its entire length. In this study, we focused on left anterior oblique corner view for the right coronary artery. With the new technique of dynamic angiography, we fulfilled the contrast into the coronary artery, and as the ejection is stopped, the blood in white color moved in and displayed the contrast in black color. So the morphology, movement, and interaction of the blood flow could be clearly observed in white on the black background of the contrast media. As you can see here, the difference between the panel A and panel B at the white arrowhead. Then the coronary flow were identified and the data were analyzed to measure the duration of the arterial phase, also as the presence and duration of the retrograde flow and spilling. This is the flow of movement in the right coronary angiogram. The first image showed that the artery is filled with contrast, while the blood at the black arrowhead is seen moving into the proximal segment of the RCA. Then the blood courses distally through the artery along the pieces of the curve. And now the contrast became blurred due to its passive diffusion into the blood. Overall, 20 patients who met the inclusion criteria enrolled in this investigation. 15 of them were with moderate aortic stenosis and 5 of them with severe aortic stenosis. As we see in this table, there is a huge difference of duration of arterial phase among 3 types of patients, especially severe aortic stenosis, which is 8 seconds, and normal patients, less than 2 seconds. Patients with aortic stenosis have significant recurrent reverse flow in the proximal coronary segment with ejection back into the coronary sinus. The first picture showed that the contrast could be seen coming out from the RCA ostium, filling into the aortic sinus. Then the spillage area became darker because more contrast was spilling out. So the main findings of this current study are the prolongation of arterial phase and reverse flow in the proximal coronary arteries in patients with severe aortic stenosis. Previously, the coronary flow was measured by using the speed of the contrast flow, known as the TIMI frame count. There are 2 critical differences between the TIMI and the novel technique study. First, in the present work, the speed of the flow was the blood itself, not the injected pressure. So the blood has no interference from the operator nor the motorized injector. Second, this new technique allows for the measurement of retrograde flow, which was impossible by the TIMI frame count because the TIMI was based on the flow of the contrast under positive forward pressure. On the other hand, the novel technique documented that the direction of the blood could reverse during systole and move forward during diastole, as in normal coronary physiology. So it is reasonable to suggest that the consequences of prolonged arterial phase are significant concerning adverse patients' outcomes. The time delay of renewed oxygenation to mid and epicardial myocardium can be attributed to initiation of chest pain and may trigger near fatal or fatal arrhythmias, culminating in syncope and sudden cardiac death. And the presence and persistent retrograde injection of contrast from the coronary artery into the coronary sinus were the most substantial evidence of extreme constriction of coronary artery during systole in aortic stenosis. Once reverse flow and the contrast spill at the coronary ostium were documented, the severity of aortic stenosis could be confirmed. So these patients could be sent directly to surgical or percutaneous aortic valve replacement without calculating aortic valve gradient and aortic valve area. However, the study suffers from many different limitations. First, this is the non-randomized observational study with small sample size. Second, the data were recorded in retrospective fashion. And last, the impact of confounding factors cannot be assessed. So, a large cohort would be needed when working on general population. Finally, with this new understanding of mechanism of ischemia, effective strategies for prevention and management of ischemia, syncope, and sudden cardiac death can be developed and more positive patient outcomes achieved. Thank you for allowing me to introduce our study. I am very happy to answer your questions.
So Thank you for your presentation. So I would like to invite a question from the judging. So I would like to ask Professor Giám, Professor Ernest, or Talarico.
So,
any questions?
I have an idea. Generally, I high appreciate all activities of scientific research in the student. But as the topic, last topic, I think that many research related research ethic, related research ethic, that is the permission by the committee. So if possible, you can focus the level of student. Many factors, many details we can perform the research, scientific research with the same level. So with a technique like that, I think not only the general doctor but also they don't have the certificate, practicing certificate, chứng chỉ hành nghề. Tôi xin nhấn mạnh như vậy. Practicing certificate, because it can cause the death of patient. So anyway, generally I appreciate your activities, but I think that the result, the higher the level, the permission of the student. So we need the real activity, the real result of the student. That's my idea. Thank you.
Thank you for the opinion from Professor Giám. So you just answer very short answer for me. That's how you apply your research of your topic to the artificial intelligence in diagnostic imaging.
Sorry, can you repeat the question?
So how you apply your research of your study to the artificial intelligence in diagnostic imaging? So you can skip. Just ask about artificial intelligence, because it's some topic in this section is talk about the mechanism in the finding the stenosis of coronary artery. So it's support the artificial intelligence in diagnostic imaging is very important. So I would ask your opinion. So because we didn't have enough time, so we move to the next topic. So I would like to introduce Phang Vu Khanh Vân with topic measuring the boundary layers in the patient with acute coronary syndrome by dynamic angiography and machine learning program. So please give your presentation.
Good morning, everyone, and welcome to my presentation. I'm Vân Phan, 6th-year medical student from Tân Trạch University. I appreciate the opportunity to be here today to present our research. What I would like to present to you today is measuring the boundary layers in patients with acute coronary syndrome by dynamic angiography and machine learning programs. Before I start my presentation, I would like to say thank you to co-authors for their support and hard working. The presenter and co-authors have no relevant financial or commercial relationship to disclose. This presentation contains 4 main parts, that is background, methods, results, and discussion. So we begin by filling you in on the background. Study in this laboratory hypothesized that damage to the tunica intima of coronary artery was caused by cavitation phenomenon or rupture of bubble, which was seen frequently in domestic and industrial pipes. The cavitation phenomenon occurs secondary to abnormal flow hemodynamics resulting from differences in pressure between the layers and segments of coronary blood flow. Let's now look at the next slide. On the left side of the screen, this is the graphical representation of Bernoulli principle in cavitation and bubble formation. And on the right side of the screen, is the graphic that presents the bubble formation and implosion. Let me quickly explain the graph on the left. When the static pressure is lower than the vapor pressure, air bubbles are formed. When the static pressure recovers higher than the vapor pressure, the air bubble will implode. Let's now look at the graphic on the right. When the bubble implodes, creating dynamic pressure on the bubble, surface tension of the bubble breaks and bursts, creating microjets that trigger acute coronary syndrome and blank formation. Initially, the analysis of coronary angiogram, duration or percent of abnormal essence and flow was done manually. However, as this individual reviewing methods was time-consuming and relying on human resource, analysis of coronary image by artificial intelligence programs was suggested as a possible solution. Moving on to the method. In the conventional reviewing protocol of coronary angiograms was done with the construct injected until the index coronary artery was completely opacified. As the injection of construct stopped, the blood in white color moved in and displayed the construct in black color. The morphologies, movement, directions, and interaction of blood flow, white color against black background, were reviewed frame by frame by the angiographer or investigator, 15 frames per second, adjusting for lessons and analyzing flow dynamics. Next, I would like to present about the application of computer science by deep learning algorithm. We have two steps: pre-process data and classify the flow, which I will talk about later. Pre-process data. First, extracting the data is the image from the angiogram's video. Then, labeling data by quick selection tool of C6. This is the image and image labeled. After that, using UNet combined DenseNet 121 for building segmentation model. Here is the UNet combined DenseNet architect. For the unclearly one, the image would be incorrect. There was area of broken lines in the vascular shape. Our team provided a solution. We cropped the blood vessel area based on the upper, lower, right, and left boundaries with white pixel. This is the segmented image for machine learning. This angiogram here is what we're selecting. This is the mass, and here is the segmentation model. When I look at this mass here, it's not immediately apparent to me which part of the vessel is the area is concentrated. We pre-process this image. The mass is created, so the UNet use this information to create the segmentation model that AI used to compute the pixel, dark for construct, white for blood, and it can look at that across time, so it can examine the blood flow and stagnant. Next, we will come to classify the flow. First, select the dataset for classification model. Then use the convolutional neural networks for classify the blood flow. After that, calculating the number of stagnant flow. Convolutional neural network were used for building classification based on the segmented image. Here are the picture of normal flow. The area of construct in the vessel mixed with the blood is very uniform. And here is the picture of stagnant flow. The construct is formed like the separated layers. It takes time to be washed out. Turning our attention to the results. In total, 261 patients were included. Model 1 segmentation model. The size of training dataset was 3,630 images, randomly exported from angiogram video. Model 2 classification model. The size of training dataset was 1,019 images, which is contained 505 stagnant flow images and 514 normal for training. Here is the result table. The validation accuracy of Model 1 was 94%. The validation accuracy of Model 2 was 93.9%. Sensitive of machine learning in the detection of stagnant flow was 91%. The specificity was 96%. Its positive predictive value was 95%, and the negative predictive value was 96%. All of that comes to conclusion. In the investigation, so that we can build the machine learning protocols that could function accurately to assess the flow in coronary arteries. The limitation is that we need a larger amount of input data to have the training programs. That's complete my presentation. Thank you for allowing me to have the opportunity to present here today.
So thank you for your presentation. So I would like to ask about the judges, Professor Zàng.
Yeah. I have a question. As the former study, I think that with the student like that, you perform this technique very important. So the high appreciation. Anyway, so can you answer me that what is the side effect of angiography? What is you can tell me about the side effect of the angiography? Thank you. Are you here?
So,
thank you for your wonderful question. To answer your question, I have to say that I am joining the technical team, so I don't really know much about the side effect of angiography. But to answer your question, I will try to contact you later, and I will try my best to send you my answer after this conference. Yeah.
Then I can say that there are many complications of the side effect of the angiography. So it's very strange that you're a student. So anyway, you can try with the time, okay? But in terms of theory, at least you can know that can how and infection and kidney damage, heart attack, for example, many. So I for the student you studying. So in terms of scientific research, it's possible, okay, but you should focus in the zone level of capacity and knowledge instead of the advanced technique like that can cause many complication, even the death of a patient. You see that even with the theory that you don't know it perfect like that, it's not good. So
excuse me, I think there's some problem about your connection. I cannot hear you clearly.
Thank you for your answer. So we know that the machine learning program is a very modern technique. Our study now is we are research about artificial intelligence, especially machine learning program. So thank you very much for your topic. So we move to the next. So I would like to introduce student Thang Le with the topic performing coronary angiographies with the artificial intelligence program. So please give your presentation.
Good morning, ladies and gentlemen. I am Trần. I'm from Normandale College, Minneapolis, in Minnesota, in the United States. I am here today to present my project in estimating the severity of coronary lesion, size and length of the arterial segment for stenting and flow dynamic procedures by artificial intelligence program. To begin with, I have no conflicts to disclose. First, for the background, we are now in 2021, an era of technology where almost any people in the world will have at least one computing device for themselves. Technologies companies have also been developing and starting to implement artificial intelligence in multiple machines with multiple functions. Meanwhile, in medical, artificial intelligence is a hardest trend in radiology, for more specifically medical imaging. Overview of the type of AI software being developed and a few examples that are specific to cardiovascular imaging. At this present time, we have 4 main areas where AI is being reported based on Radiological Society of North America meeting. The first one is computer-aided diagnosis. The second one is clinical decision support. The third one is a quantitative analysis tool. And the last one is computer-aided detection. Before we get further into what we can implement into cardiology, I want to elaborate more about artificial intelligence. So, what is AI and how does it work? Artificial intelligence, or AI, is the simulation of human intelligence by computer machines, especially computer systems. Specific applications of AI include expert system, natural language processing, speech recognition, and machine vision. AI is become more popular due to the capability AI can do in a lot of aspects, as we can train it to do more than just. And AI also works by combining large amount of data with fast iterative processing and intelligence algorithm, allowing the software to learn automatically from patterns and features in the data. So, as we already know what is AI, how does it work, but how do we implement it in angioplasty? AI. So, in order to facilitate the investigation of coronary lesion and flows, systematize the protocol and shorten the time of individual review of coronary angiograms, artificial intelligence or AI program for use to investigate the flow dynamics and the absence of severity of lesions. There are also 4 steps that we can implement it into performing ballooning angioplasty and stenting. The first step is the segmentation vessel. The second step is to measure the severity of the stentonic area, estimating the diameter and the length of the coronary segment to be stented. And the third one is to suggest the stent based on the diameter and length of the coronary segment. And the last step is to identify the type of flow. To be more specific, we will start looking at the first step. For the first step in segmentation, we will extract the video from Epic, and it will be exported from 50 FPS by OpenCV on Python. The frame will be labeled and will be processed by the selection tool of CS6. We will use UNet combined with Net 2.121 to build a segmentation model. The segmentation model is present here. It shows how the AI works. The left column of the image, so the image data that will input in the AI, and it will be processed by using the algorithm at the left. It will be built by the model shown at the right column. So here's the A1, that's both of here, and the B is over here. After the model was built, we will move to step 2. For this step, we will calculate and locate the lesion by using deep center line algorithm to building the center line. Then we will create a point in the vessel center line, and it will also use the linking edge algorithm to to calculate the size of the coronary artery, and the percentage of the stenosis of the vessel will be defined as P equal 1 minus D mean over D max, or times 100. Meanwhile, D is also the diameters of the vessel. These figures are the representations of how the AI brains compute the diameter of the artery. And move on to the third step. By basing on the diameter of the coronary arteries and stenosis area and the estimate of the length and single small straight perpendicular of diameter of the center line, the AI can predict the correct stent size for the patients, and cardiologists will have an easier time choosing the right stent for the patient. And for the final step, we will start identifying the type of flow by creating the dataset for type of blood flow, combined with applying the CNN model, also known as convolutional neural network model, for classifying data for recommended type of flow. As a result, the data set for training the segmentations was 1,815 image and 1,815 label image. For the in step 1, after 100 epoch training sessions, the accuracy was 94% approximately for the main vessel and 85.15% for full vessel. However, with more trains, AI can be improved with more accuracy and lower time consumption in processing data. Step 4, classification model with step 4, accuracy also approximately was 93.9%, and it can also be improved with more accuracy and lower time consumption. There are still some small limitation for the algorithm. We only have a small amount of patients that can be tested. The different variation from different people might make it harder for AI to detect, and some cases does not show the correct contrast process in the coronary, and it can be caused by mobility of the vessel, changing size of coronary in each frame. In conclusion, interventional cardiologists can shorten down the duration of the procedure and achieve better result with less target, less lesions, revascularizations. Also, with less optimal time, cardiologists will only need no attempt to repeat angioplasty for stenting. It also suggests that AI can save a lot of healthcare expense for the patients and society. And that's all for my project. Before I end this project, end my presentation, I would like to thank for any representative that made the conference possible. Dr. Nguyen for inviting me for the conference, Dr. Le Vu and Talarico for helping me with the project and improving the project, and all the patients that have contributed to the projects. Thank you for the attention. That's all I have for today.
So thank you for your nice working. So I would like to invite Professor Ernest Talarico. Do you have any opinion?
Can you hear me?
Yes.
Yes. No, I think it was a very good presentation. I guess I'm a little bit biased because I mentored him a little bit. What do you think? How can the study be redesigned or improved to overcome some of the limitations, other than just getting a larger sample number?
So Thang Lê, do you hear clearly?
Is he muted?
Okay, now I can hear, so you can repeat your answer, Thang Lê.
I still cannot hear.
At So Professor Ernest Talarico, so you please repeat your question.
Well, my question was, is how would you redesign to improve the study, okay, so that you can incorporate some of the limiting factors other than just bringing in a larger sample size?
Can you hear me now?
Yes.
Okay, next. I think that as for the first one, I think you can improve it more by like improving the software, like to like how to know how it code, like how it program, and we can get like send the AI some examples so it can improve it later by learning. And yes, it's similar for the different model, like for different body anatomy. Yeah, I think I probably can improve it in the future. That's all I have. Anyone have questions?
So how about your other opinion from Professor Ernest Talarico?
Oh, you mean me? You asking me?
No, I would like to ask Professor Ernest Talarico.
Oh, okay.
Are you asking my opinion on how the study can be improved? I think, of course, a bigger sample size, but we also know that in different populations, there are variations in the diameter, the size, and the pattern of the coronary arteries. So, like Tang says, somehow this information needs to be programmed into the brain so that the artificial brain can take into account this information when it's analyzing the data, and that would also produce a more accurate results. Similarly, when the heart is in motion, the diameter of the coronary arteries also changes, and that can be seen on the dynamic angiogram. And again, the models also need to be able to take this into account in order for the AI brain to give a more accurate result.
Yes. So thank you for the very experienced opinion from Professor Ernest Talarico. So how about the other jury member? So do you have any more questions? So because we don't have enough time in this session, so thank you very much from your presentation. From the student Tang Lei's very nice booking with the program that can save the healthcare expensive for the patient and society. So please invite Professor Vũ will conclude about this session.
And this session finished now. Thank you very much for everyone who participated in this session. And I think the prize for all the presenters was the detailed prize, so you know, at the end of the conference. And thank you very much. Thank you for panelists.
Yeah. So thank you for every jury member. So we have the group yellow group. So we will discuss about the result in the yellow group. And for Professor Ernest Talarico, we will contact with you by email. So we stop the session here, and so we move to the next section. So thank you.
Thank you. Thank you very much.
Thank you.
Thank you. Nicely done.